Okay, so I'm going to talk today about management of the overcorrected adult clubfoot deformity, which is an interest of mine and has been for some time. When you look at the foot, you'll all recognize this. These are flat feet, but it's not just that the foot is flat. These feet are interestingly fairly plantigrade, but are terribly dysfunctional, both in the hindfoot as well as the ankle and the midfoot. What I'm going to do is break it down into the younger adult, the older adults, and then we'll look at the forefoot, midfoot, hindfoot, and ankle in different sections as to how this can be addressed and treated. So this is the common issue. We've got a plantigrade foot. Note how laterally translated the calcaneus is. You've always got that slight indentation in the subtalar joint with the valgus of the heel, but in general, you've got a plantigrade foot with respect to the heel and the forefoot, unless you've got metatarsus elevatus. So what is the problem? Here we see a very typical X-ray. The foot is flat. You've got metatarsus elevatus, and I want you to start to think about the cause of that metatarsus elevatus. That leads to very limited function in the hallux and a flat top talus with obvious rigid hindfoot valgus. And that's generally the composition of all of these problems. Some varying degree of hallux dysfunction as a result of the metatarsus elevatus, some midfoot stiffness. The hindfoot is always stiff, and then we'll have varying degrees of problems with the ankle. In the older adults or those with more advanced disease, this is not necessarily restricted to the older adult, but usually this is when we will see this type of problem. You'll see more issues with the ankle and more problems with ankle impingement, and then later on, even worse still, you'll get ankle arthritis. Midfoot pain, and you can see why. The navicular is so dysplastic, you usually get breakdown at the navicular cuneiform zones. So in the younger adult, if you look at the AP view of the foot, there's generally a skew foot. And you can see that there. If you look at the relationship between the talus, the segment in the midfoot, and then the forefoot, you've generally got metatarsus adductus, which is a residual of the childhood talipes equinovarus. And this is the same thing in the older adult or the more advanced disease, excepting for the fact that there's arthritis present. So there you'll see the skew foot deformity, which is very, very common, and you've got arthritis at the talar navicular and navicular cuneiform joint. So let's come now, we'll go a little further back. What about the ankle? The ankle is what will bring patients to see you. And it's curious that in the adolescent and the young adult with this problem, you see a horrible looking ankle, but it's not always that symptomatic. The problem is hinging. Because of the flat top talus, there's no concentric motion at the ankle joint. And when you look at the way they're actually moving, they're not really moving much at all. It's jamming and impinging in the front of the ankle, and they jam and impinge in the back. Here you can see more advanced disease, and obviously not only is there going to be hinging, but there's also arthritis. This is what you'll see in plantarflexion, and then of course in dorsiflexion, you've got this terrible hinging with early arthritis. Now, all of these deformities that we see are in some way the result of overcorrection. Clearly, the generation that has grown up in the past decade or more with the Ponseti treatment, you're not going to see as many of these problems. In fact, you won't see that many at all. It'll be a slightly different spectrum of problems that's going to be present. But in general, when you look at the deformities that I'm showing you, these are the result of overcorrection. So what is our goal of treatment? Well, you want to correct deformity. You cannot just approach this as if you're treating arthritis. If it's just a matter of treating arthritis, you will never resolve the problem. So in other words, you're not just going to do a triple arthrodesis to correct the rigid flat foot. You have to correct deformity. So let's go through this deformity correction, because in deformity correction, what I'm talking about is not just arthrodesis, but also balancing the foot, for example, with a tendon transfer. Okay? So let's take this patient, 19 years old, and she presents not with any hindfoot dysfunction or hindfoot problems. In fact, her ankle is actually in fairly good shape, the forefoot. So she's got a problem with her hallux, and let's see why. If you look at what's going on there, you can see that you've got metatarsus elevatus and jamming of the hallux. So it becomes easy to understand when you look at the pathogenesis of this. The anterior tibial tendon is very strong and very functional. And of course, the balance of your anterior tibial tendon is your peroneus longus. So clearly there's no peroneus longus that's functioning in these patients. And you've got an anterior tibial tendon overpull, which then pulls up your first metatarsal. That then leads to problems and shortening of your flexor hallucis brevis. Think of your intrinsic construct around the hallux, so your FHB contracts, and as that comes down, it then pushes the hallux up even further. So anterior tibial tendon overpull for metatarsus elevatus, then you get contracture, it pulls your sesamoid complex back, that pulls the hallux down, and then you get even further worsening of the hallux deformity, because as the hallux goes into a fixed flexion, it then pushes the first metatarsal up even more. Okay, so here you've got a typical deformity. You're going to hear my music is on in the background. I apologize because I'm giving this talk through my computer. So let's look at this. Look at the hallux and the range of motion in the hallux. Fabulous range of motion in plantar flexion, but very limited motion in dorsiflexion. In fact, this is not that uncommon. It's almost the reverse of hallux rigidus. Now we'll go to what I'm going to do. What has to be done in order to get your first metatarsal down is to move your anterior tibial tendon. And in fact, that's the very first procedure that I do when I've got metatarsus elevatus, is to move my anterior tibial tendon somewhere. We'll talk about where it goes later. Now what you'll see is after I've fixed the first ray in position, I've now got great dorsiflexion of the hallux. So now let's go back in sequence and decide what you're going to do, because your anterior tibial tendon needs to be moved laterally, and I generally will put that either into the lateral cuneiform or the cuboid. To some extent, it doesn't matter terribly much where it goes, provided the tendon is actually moved laterally. I don't find that a plantar flexion osteotomy of the first metatarsal is enough, so that I'm usually going to do an arthrodesis of the first tarsometastarsal joint and remove a small wedge from that joint from the medial side. That's why I've got a medial incision, so I can harvest the anterior tib and do my first TMT fusion at the same time. And this is what it looks like once I'm done. With very, very nice range of motion of the hallux. Here you'll see where the anterior tibial tendon is being moved laterally. In this case, I suspect, I don't remember, but I think I put it into the cuboid in order to lift up that lateral side of the foot. It does not surprisingly weaken dorsiflexion all that much. I want you to notice something on the screen here, and that is that over the front of the leg, there are 3 little marks over the distal tibia. I made those marks anticipating that I would need to make a second incision there. In order for your anterior tibial tendon transfer to work, you have to completely release the extensor retinaculum. You cannot pass this underneath the extensor retinaculum. you've got to release it, because if you try to pass it under the retinaculum, it gets kinked and you will lose extensor function. So here you can see this is what it looks like, and now we've got a very nice plantar grade foot. Oh, look, there we go. This is looks like it's in the lateral cuneiform and not the cuboid, as best as I can tell. Now, why did I use K-wires for fixing this tarsometatarsal fusion? Sometimes in these cases, the surface of the joint is so flat that it's almost impossible to get screws in there. I guess you could use some staples or a medial or plantar plate, but I find that K-wires every now and then is more than adequate. So let's take another example here, a 19-year-old female, and she's now 18 months following correction. And this is what the foot looks like. So if you focus now only on the midfoot and the forefoot, you'll see that there's been a very nice dynamic improvement of the position of the first metatarsal with a plantar grade forefoot, and as indicated, the goal of improving function of the hallux has been attained. Now we'll move to the hindfoot in a younger person. As I said, you've generally got a rigid hindfoot valgus with some change in the hindfoot function. In this individual, you've got a terribly rigid subtalar joint and a fixed subluxation of the talar-navicular joint. Now this varies a lot. Sometimes your talar-navicular joint is flat, sometimes it's subluxated, and sometimes I'll show you a case where your talar body is so tilted that it looks like a vertical talar. So this was treated with a talar-navicular fusion and a calcaneal osteotomy. Now this doesn't look pretty, and clearly there's going to be significant hinging still present in the ankle. But since that was not her symptom complex to begin with, my goal here was simply to realign the hindfoot, which was giving her trouble, and addressing the metatarsus elevatus. So I did an anterior tibial tendon transfer, and that, as I said, almost always done, and that's combined with the hindfoot fusion and osteotomy. Now, if we look at this here, you'll see, again, severe metatarsus elevatus, and peculiarly, the ankle function in this case is reasonable. Why? Only because if you look at the declination of the talus, you've got significant increase in the talar declination angle. You don't really have a flat top talus here. This foot is a little bit different. The ankle function here is reasonable, but your goal remains the same. I want you to look here at the elevated first metatarsal and the fact that it's very long, okay? This aggravates the problem with dorsiflexion of the hallux. So imagine you're dealing here with hallux rigidus with a very long first metatarsal and an elevated metatarsal. Well, the obvious solution then would be to shorten the first metatarsal, and that's what was done. Here you can see the foot, and if you look at what was done here, I had to do the hindfoot. This was a very, very significant deformity of the hindfoot, and I shortened slightly the first metatarsal. And you can see now the metatarsal is better aligned. You've got slight shortening of the metatarsal. I've plantar flexed my tarsometatarsal joint and done the triple arthrodesis. But again, just to remind you, with the anterior tibial tendon transfer, you can see the anchor. It looks like it's coming in from the middle or lateral cuneiform where I inserted it. So the principles remain the same. Plantar grade foot, get that first metatarsal down. Here we have a much more severe form of this, where if you look at the terrible metatarsus elevatus, the talar navicular joint is dislocated. Look at that again, and there's your navicular, and there's the head of the talus. So this is the equivalent of a vertical talus in the adult. But again, with overpull of the anterior tibial tendon, absent function of your peroneus longus, and the same set of contractures of your flexor hallucis brevis. This is what the foot looks like. You can see a very significant deformity. You wonder how on earth this poor lady has been walking on this for all these years. So here you'll see what's being done. To start with, I get rid of the force of that anterior tibial tendon, and I'm going to move that laterally. You can see now I'm able to at least I can pronate the foot a little bit better because the anterior tibial muscle is not pulling up on that medial column as much. Now that I've got that freed up, I want to transfer my anterior tibial tendon. Now this is what I was talking about earlier, where you've got to release that retinaculum in order to get the anterior tibial tendon to move and glide correctly laterally. That's why I've just extended the incision a little bit more on this here. Now you can see what it looks like. I've fixed the medial column, in this case with Steinmann pins, and I've got a nice plantar grade foot. If you look at the X-ray is not going to look all that pretty. This is what it is. It's certainly not normal by any means. Now, you say, well, why did I use these pins and not some other form of fixation? Since most of you are accustomed to seeing screws and plates and so on with your hindfoot. Think about it. Look at where this tailornavicular joint was and where it is now. It's almost impossible to get any secure fixation to this bone, and using Steinmann pins is quite adequate, particularly since the patient is non-weight bearing for a period of time. This is what the foot looked like perioperatively. Now here we have a failed attempted correction. And if you look at this, it's very easy to understand why. Because the problem wasn't addressed. A fusion was done at the hindfoot and an attempted fusion of the tarsometatarsal joint. So the problem was sort of recognized, but you cannot correct deformity like this unless you balance the foot. And the balancing of the foot comes with neuromuscular balance by shifting your anterior tibial tendon. So this is what was done. There was a non-union of the tarsometatarsal joint and, of course, quite severe deformity with ankle impingement. So in order to correct this, not very difficult, you've got to redo your hindfoot arthrodesis and bring that medial column down and transfer your anterior tibial tendon. That's what was done. So I plantar flexed the tarsometatarsal joint, redid the triple, and of course, as I've been discussing, move your anterior tibial tendon. In this case, that calcaneus, the hindfoot was in such severe valgus, I shifted it medially in addition to everything else that was done. And you can see if I go back, I'll just go back a little bit, that anterior ankle was impinging, so I added a chilectomy there of the front of the ankle. Now, I'm going to move back now, further back, and we'll discuss the ankle in this setting. And here you'll see this is a difficult, very difficult deformity. Why? Because you've got an almost cavus-looking foot. You've got a flat-top talus, so this is a bit unusual in the setting of what we've been talking about, but you've got a cavus foot with a flat-top talus. And the reason this gets to be difficult is we're going to talk about managing this ankle impingement. If you look at this here, you've got an obvious source of the ankle impingement. The body of the ankle doesn't look all that bad. So perhaps this could be salvaged, just, which is what I did, just by doing a very aggressive chilectomy of the front of the ankle. Very aggressive. I took down a lot of the tibia and that dorsal lip of the navicular. The ankle still didn't function all that well, but it got rid of pain. You're not going to get that much more movement out of these anterior chilectomies, but you will get a decrease in pain. Here we have a similar problem, but my question would be, is a chilectomy indicated or contraindicated? Look at this here. You've got a chilectomy done, yeah, and that looks pretty reasonable. But what sometimes happens is that you then unmask ankle pain. It's the same thing in patients with post-traumatic anterior ankle impingement, where if you do an aggressive lectomy and free up the ankle, then you have early ankle arthritis which you now unmask. You can't expect this ankle to function all that well. So the goal of the colectomy is not to improve motion in the ankle. You must tell the patient. The goal is to decrease that pain from anterior impingement. Here you'll see a similar problem where if you look at this hinging here, there's terrible hinging, and that's going to persist. You're not really going to be able to improve that, but you will be able to decrease the pain from anterior impingement. The motion in the ankle stays the same, and it's very important to realize this. Now, here's another concept, and that is if we keep on this idea of hinging of the ankle, this is a woman who many, many years ago I did the midfoot and hindfoot realignment for the anterior tibial tendon transfer. She came back then about 10, 15 years later with anterior ankle pain. And you've got to be very careful in trying to get more dorsiflexion. The only way you can help her is just to decompress the front of the ankle. So when you try to improve the ankle motion, I think you're looking for a little trouble. Now, here's a very interesting concept. Marcus Knapp and Beat Hinterman have published this, and I'm not so sure that this is correct. And I've discussed this with them, and you'll see why. Look at what they do. They do an anterior closing wedge osteotomy of the tibia. Now, think about this in the exact same context as a Moberg osteotomy for the hallux. If you've got a patient with hallux rigidus and you do a Moberg osteotomy, what is that Moberg osteotomy doing? All it does is lift the hallux off the floor. Same thing here, this lifts the distal tibia off the ankle. What they found was that the range of motion only improved a few degrees, and that was because they did a chilectomy in addition to the osteotomy. So you've got to be very careful with your goal of this type of osteotomy as well. Here we have the youngster with a cavus foot in the flat top talus with terrible ankle pain. So for this, I think a TTC arthrodesis would be indicated and quite reasonable. Here we have a similar problem with ankle pain, and you have to decide where do you draw the line. Could you do an ankle replacement on a patient like this? And I'll talk about this. Or do you need to do an arthrodesis? You've got quite marked deformity, and I think that an arthrodesis for these patients is preferable. If you go back, remember that these ankles don't function all that well to begin with. They are hinging. You're not going to get all that much motion when you do a replacement because of terrible soft tissue contracture circumferentially. So I think an arthrodesis with realignment, and don't forget the anterior tibial tendon transfer. If you look at this carefully, in order to get this foot plantigrade, look at that first tarso-metatarsal joint which is broken down, so clearly that needs an arthrodesis, but you want to decrease that elevation on the medial column. This individual, I'm going to plan a TTC arthrodesis, but I want you to think about the position that you're going to put the foot in. This is a very, very difficult case, and look why. Here I've got my arthrodesis, and the arthrodesis is successful, but if you look at this carefully, the forefoot is in a little bit of equinus relative to the tibia. Now this is hard. Why? Because if you wanted to try to correct that forefoot equinus, you've got to lift up your arthrodesis a little bit. There's the equinus. Now think about this differently. If you want to bring the forefoot up like that, automatically that brings the calcaneus down and you increase the calcaneus position, which is intolerably uncomfortable. So it's preferable in these patients actually to leave them in just a little bit of equinus or you've got to do a pan-talar fusion and then take a wedge out of the transverse tarsal joint in order to correct it. So here you can see the final question is, what is the role for ankle replacement? There are a couple of issues with ankle replacement in this setting. One, the ankle is terribly, terribly stiff to begin with. You don't get all that much motion back in the ankle. And the second and perhaps more important issue is that these are tiny ankles. These are small ankles, and the fibula is so far back posteriorly that when you cut your tibia, you invariably have to cut a little bit into your fibula as well in order to fit your prosthesis. Those are small ankles, and the fibula is posterior. So here we've got a case that Bill McGarvey gave to me, which he was able to accomplish very, very nicely. This is actually a very good correction of a difficult deformity by derotating the hindfoot. I don't like the position of the midfoot here because you've still got a varus deformity of your midfoot. Look at the position of your fifth metatarsal relative to the axis of the midfoot, and the fifth metatarsal is still on the floor. So you've got a nicely positioned ankle, but I would have derotated the midfoot a little bit to make the forefoot more plantigrade. In the literature, there's not very much written on this. This is the entire literature going back decades on problems in the adult clubfoot. I'll finish off. I've got a video here just to show you. And look at this patient walking here.
And come on
She's
back.
a physical therapist who's managed absolutely brilliantly with exercise and tennis for most of her adult life. And now she starts to decompensate just because of pain in the ankle. So you've got to decide how you're going to address it. As I said, I don't think a chilectomy is ideal. An arthrodesis is probably preferable. And as an alternative, you can always consider an osteotomy. All right, thank you very much. We'll open the line. And if you have any questions, you can present them now. Or you can even just type them in to me in the chat box.
Thank you. I will go ahead and open everyone's lines. It may be a little bit loud at first. If I am detecting a lot of static from your line, I will mute it. And then if you have any questions, please defer to using the chat function. So here we go. Okay, do we have any verbal questions at this time for Dr. Myerson?
So here's a question. Do I use a peroneus brevis to longus plantar? That's an excellent question. Excellent. So the answer is yes, sometimes. Think about the function of the lateral foot. We know that there's no peroneus longus function. The only problem is that in the older adults, when you've got rigid deformity, transferring the peroneus brevis to the peroneus longus does not really work. One of the problems is that when the peroneus longus is released in these club feet, generally it's cut from the medial side of the foot. So transferring the brevis to the longus, all that will do is weaken eversion. It doesn't actually increase the function of plantar flexion of the first metatarsal. So that's a very good point.
Again, feel free to type in your questions, or you may verbally ask questions at this time if you wish.
All right, everybody. With that, then I'm going to close this session. Thank you for participating. Bye.